Hey, everybody. I'm Sharon Forsyth, Executive Director of the Alpha-Gal Alliance. Welcome to our webinar, Alpha-Gal Syndrome Surveillance in Virginia. Numbers matter, and for the Alpha-Gal Syndrome community, documenting the true extent of Alpha-Gal Syndrome is absolutely critical for securing the support of both decision makers and private investors who have the potential to invest in therapies and potential cures. So alpha-gal syndrome has only been reportable in Virginia since September 2025, but Virginia is already at the forefront of developing novel approaches to documenting the extent of alpha-gal syndrome in Virginia. So today, um, uh, we've got some folks here from the Virginia Department of Health who are going to be doing a presentation on public health strategies in general and in Virginia specifically, some of the novel approaches that they're taking. First presenter is Virginia State Public Health Veterinarian Julia Murphy. She's leading this effort. And Julia will be joined by Virginia State epidemiologist, Virginia State entomologist, is that right? Dr. Eleanor Labgold, and Virginia Department of Health Epidemic Intelligence Service Officer Max Weidman. Thank you very much. I did want to mention, if you have any questions, stick them in the question and feature. There's a question and answer feature in the webinar. The chat's off, and we will try to answer as many of your questions at the end of the webinar. So with that, Julia, I'm going to hand things over to you.
Well, thank you, Sharon. I appreciate being part of your evening and everybody's interest in this. I'm again, as Sharon said, I'm Julia Murphy. I serve as the state public health veterinarian. I'm very, very fortunate to have with me two people who are key to this effort and really are helping out with figuring out how we're doing alpha-gal surveillance in Virginia. And that's Max Weidman, who's a physician and also an epidemic intelligence service officer and state public health entomologist and new mom, Eleanor Labgold. So we have everybody here with us tonight. What I thought I'd do is I'd start us off with just sort of a primer, an overview of public health surveillance, what it is, what are the different types of public health surveillance that a health agency may do, and then we'll drill down a little bit further into what we're doing in Virginia in regard to alpha-gal surveillance and the kind of strategy we're trying to use to figure this out and gather good data for public health action. But I thought if we started off with maybe a high-level 30,000-foot view primer, it might help complement the information that we're going to be presenting about alpha-gal surveillance in Virginia in specific. So what I may do is, Max, if you want to share your screen, and what I might do is, because I'm at home in Goochland County where the ducks run barefoot and the internet can be a little shaky. What I might do is I might go off camera, but then I'll pop back up for the Q&A and such like that. So what I'll do is if I can figure out the electronics, I might go off camera here. And then that way I'll be a little more of a steady Eddie on my internet service, and we can start ahead with the program. So the first thing I thought would be helpful to present, if I could have the next slide, just to kind of offer a basic concept overview of public health surveillance, is to define it. What is public health surveillance? How do public health agencies go about doing disease surveillance, and what is it really? How would you define it? And public health surveillance is typically defined, or certainly a good standard definition of what public health surveillance even is the ongoing systematic collection, analysis, and interpretation of health-related data essential to planning, implementation, and evaluation of public health practice, which is closely integrated with timely dissemination of the data and to those responsible for prevention and control. Another variation on a theme of what public health surveillance even is and what the definition is the ongoing systematic collection, analysis, interpretation, and dissemination of data regarding a health-related event for use in public health action to reduce morbidity and mortality to improve health. So in other words, I know it's a lot of words, and you'll kind of figure at some point that you'll realize I'm always happy to make a short story long, and these are long definitions. But you'll see some themes here in the basic concept of public health surveillance, which is it's to be ongoing, it's to be systematic. There's supposed to be some kind of analysis and summary, and the data is supposed to be used for disseminating and public health action. We don't want to collect information just to collect information to say we collected it. We want to try to collect it as best we can and use it to the most effective end we can, depending on the condition. And that if most effective end, that action may differ depending on what reportable condition we're talking about. But that's the big umbrella 30,000-foot view of why how we try to work the magic with public health surveillance. The other thing I think that's important to keep.
Just if I can
just go ahead.
Sec. I'm seeing comments, Max. It says that your slides are in presenter mode rather than full screen, and your screen view is backwards. I assume the screen view backwards would be fixed if you put it in. Yeah, I think that's. So Leah and Marissa, is that looking
Sorry
better?
about that. Sorry about that.
Sorry to interrupt. Just wanted to make sure everybody could see the slides.
No, that's all right. We appreciate it. And if something's getting glitchy along the way, if you're not hearing me, if there's a problem, just let us know. I appreciate that. Thank you. Everything good now? Everything's cool?
Everything's hunky-dory.
Okay, groovy. The other important thing to remember, so we've talked about, here's what public health surveillance even is. Here's a definition of it. And then surveillance systems, the systems typically have a few basic elements. First, you have to have a way of detecting a particular health event. You then have to have a way of notifying the health department. So there's the detection of an event. There's the mechanism by which the health department is notified. So you have to have a system that allows for that. And then that information needs to be collected and stored in a systematic way. And that data then needs to be analyzed and interpreted and used once again for dissemination and public health action. So that's the definition of public health surveillance. Those are some of the basic elements of surveillance systems. And when it comes to strategies, then in our next slide, you'll see that there are a number of different strategies that public health agencies may use to collect data. There we go. So there are some key types of public health surveillance strategies that might be used. And I'll start, we have active, passive, sentinel, and syndromic. So those, I think, fairly represent the basic key types of surveillance strategies that any public health department may use. Now, these surveillance strategies or types aren't mutually exclusive. A public health agency may use one mainly and another sometimes, or they may use them to complement one another. But let me start going through them and just presenting to you what we mean by active, passive, sentinel, and syndromic surveillance strategy, and some of the advantages and disadvantages of each strategy. I'd like to start with passive, because passive public health surveillance is really the most routine way that notifiable diseases are reported to the health department. So most routine notifiable disease surveillance relies on passive reporting. It's the most common type of surveillance. It can do a good job in providing baseline data on the health of a population. It can help monitor trends, or possibly help monitor impacts of an intervention. Now, it can have some limitations in regard to the variability and quality and completeness of reporting. And then it can have some limitations when it comes to underreporting. So some diseases, some reportable conditions that perhaps might have or might result in mild illness in certain cases may not be caught by passive reporting, because if a person has mild illness, a person may wind up not seeking any kind of health care that could result in a report to the health department. So advantages and disadvantages to passive reporting. I did want to start with that because really it is a very common way, probably the most common way, that reports come to the attention of the health department for some type that triggers some type of action. Then we have active systems. And as the name would suggest, an active system typically involves regular outreach to potential disease reporters to stimulate the reporting of specific diseases. So normally in most, I imagine most states, Virginia is one. What we have in our law are people who are identified as disease reporters. Going back just for a moment to passive reporting, we have groups of people, say, for instance, healthcare providers and commercial labs, as examples, are identified in our law as disease reporters. So they are to report certain elements of the diseases that are listed on our reportable disease list to the health department on a routine basis. In an active system, what you're doing is you are regularly reaching out to potential disease reporters to stimulate reporting of specific diseases and elements of certain diseases. And this kind of surveillance might be used, for instance, during outbreaks of disease. Active surveillance can be helpful in validating the representativeness of passive reporting systems. It can ensure more complete reporting of conditions, or be used in conjunction with specific public health investigations. Active systems are often used for brief periods for discrete purposes, like during outbreaks, or like sort of special time-limited events, or for diseases of special interest. So active surveillance, fair enough, tends to result in more complete data, but it is more resource and labor intensive. It's a more resource and labor intensive way of going about gathering this data for public health action. Then we have sentinel surveillance. So that's surveillance using a few sources that are selected to serve as sentinels. These could be doctors' offices, they could be laboratories, they could be other components of the healthcare system that are sort of elected to represent a geographic area or a specific reporting group. This type of surveillance, sentinel surveillance, uses selected institutions or groups to provide health data on specific diseases or conditions. It certainly can be useful for monitoring diseases, monitoring disease trends, or detecting outbreaks. The disadvantage of sentinel surveillance is that because it's restricted to a few institutions or groups, it can't necessarily detect events that happen outside of those institutions that are being used for surveillance. And finally, there's syndromic surveillance. Some people may be familiar with that term, syndromic. Syndromic surveillance focuses on signs and symptoms of an illness rather than an actual physician diagnosed or laboratory confirmed illness. So now you're looking for symptoms. You're looking for these constellation of symptoms that may be going up or down, or that could signal a change in the health of the community. So the case definition for a syndrome is never as specific as for a disease. So follow-up is always necessary to verify if an outbreak of a specific disease is actually occurring. Syndromic surveillance involves monitoring for non-specific syndromes, like, for instance, presentations for fever or respiratory symptoms, or gastrointestinal illness, or other indicators that we might be able to gather, like that may highlight illness, like, say, absenteeism from work or school. That may give us an indicator that something's going on, but we need to do a deeper dive to understand what exactly is happening. And the aim of syndromic surveillance is typically to allow for early detection of clusters of illness before a diagnosis would be made or confirmed and reported to public health agencies. So those are some of the sort of the basic types of surveillance strategies. Now, we can go to our next slide. There you go. Now, there are certain considerations associated with different surveillance systems and approaches. As you heard me describe, there are different ways you can do surveillance, and there are advantages and disadvantages to the various ways you can go about trying to monitor disease and do surveillance for disease trends in a population. Now, I would say that it's generally accepted that characteristics of a good surveillance system include some clearly stated objectives. So what is the purpose of surveillance? Why are you doing surveillance? And to have a system to make sure that's evaluated to make sure these objectives are being met. Ideally, it should pick up on enough of the cases of a disease to fairly represent the disease burden that exists in the population. It's good if the surveillance system is relatively simple and easy to apply, and that it has a stability to it. And by stability, I mean that the resources, like the infrastructure, the personnel needed to do surveillance, are relatively stable. Certainly, we want the data collected to be complete and accurate, especially if we're going to use it for public health action and to drive decision making. We want data to be complete and accurate. It should fairly represent the occurrence of a health condition in the population and detect health events in as timely way as possible. And it's also important, as I alluded to earlier, to evaluate the surveillance system. There needs to be some ability to evaluate the quality of the surveillance system. You can't just set it and forget it. You have to look at the surveillance system and evaluate it to make sure that the system is meeting its objectives and serving a useful public health purpose. Next slide. And here you'll see that data collection, as I alluded to before, associated with many reportable conditions, is often a passive system. And that passive system includes reporting by groups of people identified in the law as disease reporters. Oftentimes that's healthcare providers, that's commercial laboratories. There are sometimes other groups or people identified in reporting regulations that are disease reporters. And of course, then it is the public health agency's role to provide a clear mechanism by which those diseases can be reported. So you need good information technology support in order that you can receive those reports. And then those reports then trigger a public health action, one of which is often applying a case surveillance definition, which means typically gathering a bit more information in regard to many of our reportable diseases. More information would need to be gathered after that report to see if a report and a patient meets our public health case surveillance definition. So it involves oftentimes local health departments in Virginia doing investigations. We're very fortunate in Virginia in that we have a strong local public health epidemiology support and personnel that do a lot of these case investigations. And then both at the local level and at the state central office level, we always want to be applying quality assurance and quality control and being able to create reports and summaries so data can be used for public health action. Next slide. I just wanted to say a word just briefly here to focus on what I just alluded to, which is our public health case surveillance definition. I just wanted to be clear of what that is. That is a set of uniform criteria used to define a disease for public health surveillance. Notice I said public health surveillance. This definition is often a combination of both a laboratory result and certain clinical information. And it helps us be systematic and standardized in how we assess and apply a case category to patients who are investigated for public health purposes. And it helps us compare data across jurisdictions, and it helps us compare data from year to year. It helps us with the consistency in how we count cases and how we look at trends. The one thing I want to emphasize here, because I think it sometimes gets a little confused, is that a definition that we use for public health surveillance purposes for evaluation of trends of disease in the community is not to be used by healthcare providers for making individual clinical diagnoses of an individual patient. Certainly, we absolutely value our clinical partners. They are critical. They are the tip of the spear, and we value astute clinicians who can bring concerns of a public health nature to our attention. When a clinician is evaluating an individual patient, that is a different environment in which an assessment and a case assessment is being done. We are applying a case definition to look at population trends. And so we always try to emphasize that our definition that we use for assessment of a community and community health and trends over time in a population is not really to be used by healthcare providers for making sort of an individual clinical diagnosis in that one-on-one setting within a clinical environment. Next slide, please. So we want to collect data for public health action. We want to provide information that can be used for public health personnel, government leaders, the public, certain interest groups and programs to identify patients and their contacts, and depending on the condition, identifying patients and collecting information and analyzing it to inform activities like outreach and education, disease transmission and intervention, characterizing disease burden and trend, assessing effectiveness of programs, and maybe even direct treatment. Now, again, we're not just talking about alpha-gal here. This is public health. This is public health surveillance writ large, and the type of intervention that the data may be used to inform will vary. But here is a non-exhaustive list of the kinds of things that public health will do as a result of collecting that information and how we use the information for public health action. Next slide. So now we get to alpha-gal reporting in Virginia. And I just thought I'd start with a slide of a little background, a little history associated with that. So let's drill down to discussing and presenting the background, the decision-making, and the progress to date of alpha-gal syndrome reporting in Virginia. As you see, alpha-gal syndrome became reportable in Virginia in September of 2025. So we're in our infancy here. We're just beginning our journey with alpha-gal surveillance. It became reportable via an act by the 2024 General Assembly, which is not as typical. A lot of times diseases become reportable or added to the reportable disease list, usually by a regulatory action overseen by the Board of Health. But this came to us by an act by the General Assembly. Unfortunately, there was a delay regarding the implementation of the bill that passed through the 2024 General Assembly. So our leadership in the health department worked with the legislator to help help include language in the bill that there would be a delay in its implementation. And that was very helpful to us because that allowed us some time to gather data and start to strategize about how we would go about doing surveillance. And so with that delay, we were able to have a little be as deliberate as possible in how we would how we thought we would start out doing surveillance for alpha-gal to see how this might work. And ultimately what we decided on was a sampling strategy. So data is reported to us passively. So remember, we talked about passive surveillance before and what that's all about. But then we were going to take that data that was reported to us passively and take a random sample of reports for a deeper dive into case investigation. Next slide. And let's talk a little bit. I'm going to add a little meat to the bone here of sort of how we came to that. And I say we because I was so very grateful for folks like Ellie. I'm very grateful for folks like Max who are taking a deeper dive into the data that we're now collecting, and all of the people who I'm just the sort of the spokesmodel for the group of people within our division of surveillance and investigation who came together to try to strategize on this. And what we did initially to try to best understand what the burden was going to be, which by extension could inform what we were going to do, is assessment of and trying to predict the total number of reports that we were likely going to get once alpha-gal syndrome became reportable. And so what we did it was roughly a year, a little more than a year, between when the bill that passed through the 2024 General Assembly became enrolled into law and when it was implemented. So we took that roughly 12 months or a little more than 12 months to strategize. And one of the first things we did was we collected laboratory reports on a voluntary basis in the 12 months or for roughly 12 months prior to when alpha-gal became officially reportable. So in other words, we contacted commercial laboratories that do alpha-gal testing, and we asked if they'd be willing to send us positive laboratory reports on a regular basis and a voluntary basis. So this was voluntary, and some of them took us up on it. And so we had these laboratory reports coming in so we could get somewhat of an idea of what the burden of laboratories was going to be once this opened up and it became officially reportable, and we were going to be then getting and onboarding all laboratories that were doing this testing. Next slide. And I'll set us up here just a little bit about sort of what we were looking for and how we went about trying to assess things. And then Max is going to take us through some of the numbers and some of the nitty to the gritty on where we are right now. So when these laboratory reports came in, we wanted to try to understand the landscape of what these reports were all about. Certainly, we wanted to understand the total number, but we also wanted to understand things like, well, how did this stratify by health region and health district? Was it even? Was it evenly distributed geographically? Was it not? Were some areas going to have a heavier burden than others? And might that factor into some of the strategy we might develop? We also looked at the laboratory results stratified by healthcare providers and type of healthcare provider, wondering if that, could be a strategy or that's something we should consider. And then we also looked at the patient demographics associated with the reports. So now those are some of the metrics we were looking at. We just wanted to try to get a feel for the data, thinking that this data was going to help us plan and help us figure out where we go next and how we might be able to take this first step on this journey. So I want to turn it over to Dr. Weidman now to take us through some of the specifics and the data that we have so far in this early stage of our surveillance.
Thank you, Dr. Murphy. Yeah, that was a really great introduction. And we so as Dr. Murphy was saying, we have basically 12 months of data going into this new mandatory reporting system, and we found that there were over 10,000 individuals or people that had received positive alpha-gal laboratory tests during the 12 months leading up to the mandatory reporting. And so this was mainly from one large laboratory. It wasn't all of the laboratories in the state. So from that, we estimated that there's actually about twice this rate likely during mandatory reporting. And that was actually corroborated by some of the preliminary data we have that I'll get into later. But we have about 4 to 5 months of data so far, but not enough to make any sort of final conclusions. But we basically use these preliminary the voluntary laboratory surveillance to categorize the 35 districts in Virginia that do these investigations into either high or low volume based on whether or not they receive more than 100 labs per year or would be expected to receive that amount. And about 2/3 of the health districts fit into the high volume category. So more than 100 these positive labs, or we call suspect cases of alpha-gal. So this large volume required us to employ a strategy to investigate just a representative sample of the total amount of we call suspect cases in order to respect the resources and personnel that were available in the health district. So, there might only be 1 to 2 epidemiologists available to do these investigations. So we didn't want to overwhelm that system. And so we have this algorithm that was basically to assign representative sample of the positive laboratory results as cases to investigate. So for high volume, we would limit it to basically 10 per month, with the goal that the district would complete 8 investigations basically within a month of receiving them. With the assumption that some clinicians or patients that we were trying to contact in the investigation might not be responsive, and they might not be able to complete all of the investigation. So in contrast to this, the low volume districts, so if they receive less than 100, for the year leading up to the mandatory reporting, that they would just investigate all of these positive laboratory results, up to some reasonable limit, like 10 per month, because we are expecting some variability from month to month. So we have here some preliminary data. So this is data taken from the time after mandatory reporting. So basically from late September, this is up till February 17th. So as we predicted, we received about 1,700 suspect cases per month after mandatory reporting was started, and about 17% of these were assigned as investigations based on this algorithm that I just introduced, and so that was 1,264 out of 7,500, and then of these 1,264 that were assigned, 487 were initiated by the local health districts. So that's about 40% of those assigned. And then 322, or about a quarter, of the assigned investigations were completed as of this past week. And some of these, were just assigned recently, so that number might go up a little bit. But that's just to give a sense of, the kind of case investigation volumes that we're dealing with so far. And then of those that were completed, 236, or about 73% of those completed investigations were confirmed cases. So, which is, a fairly high rate, and we'll have to kind of continue following this, as we go on throughout the year to get a more reliable proportion there. But that's just kind of our preliminary look. Um, so as we go on, as I was mentioning throughout this upcoming year, we'll continue to assess how representative the completed case investigations are compared to those laboratory reports, the positive labs or suspect cases that we start out with. And then also look at whether or not districts are receiving more cases than we expected to investigate. So maybe recategorizing some of them. Also, the proportion of those investigations that are completed. So as I mentioned so far, it's about 25%. So we might try to find ways to increase that completion rate to kind of make the completed investigations more representative of the true incidence of alpha-gal across the state. And then also the completeness of the data that we receive from investigations. So making sure that the investigations are thorough and they're categorizing cases appropriately. Okay, passing it back to Murphy.
Well, thank you, Max. And so that evaluation piece is so critical because we've just started on this journey. We're giving this approach. We want to give this approach a fair shot to try to sort of right size our surveillance. Can we help balance the can we help balance the burden against the resources that we have in the central and district offices, and can we fairly represent and do we have good representativeness, and can we use that data fairly for public health action? So Max is a big part of helping to keep the finger on the pulse of the data, evaluating the data moving forward, and taking a real critical eye to this to see if we may have to pivot or make different decisions, or if possible, layer on some other strategies to help us understand more about alpha-gal trends in the community in Virginia. I did want to mention just quickly that certainly while alpha-gal surveillance is a critical aspect of what we're doing as we engage in learning more about alpha-gal syndrome and its impact on the residents of Virginia, certainly we're doing other things as well. We're engaged in a lot of alpha-gal outreach activities and planning. I know Dr. Labgold has been involved in a number of efforts to do outreach and response when it comes to various outreach activities to include media types of outreach and response. We have reached out to our reporters, our healthcare, namely our healthcare providers and our labs, to make sure that they know that alpha-gal syndrome is now reportable in Virginia, and set up a mechanism whereby those entities can report. And when it comes to outreach activities and planning, we're working with programs within VDH. In fact, we've had a couple of meetings now with our Office of Rural Health. Our Office of Communications is very plugged into what's happening with alpha-gal in Virginia and major messages and education we're trying to offer about alpha-gal. And then we're working with other offices and programs within VDH and developing partnerships outside of VDH as well to help strengthen our outreach and also force multiply in our outreach. So all critical partners there at the state and local level, both within and outside of VDH. I also wanted to, speaking of outreach and education, our online presence can be found there at the website below. And alpha-gal is specifically mentioned with resources and communication tools, both within the clinician resources tab of that particular website, as well as the diseases and data tab of that website. Next slide. just a few references there. If you're of a mind to, there are disease reporting and control regs can be found there. There's the CDC's alpha-gal syndrome page, which is really fantastic and contains a great continuing education for human healthcare providers now. That's brand new. And then they also have great training in regard to public health surveillance. Next slide. Well, we certainly appreciate everybody's interest and time this evening. I'd like to see if Dr. Labgold would be interested in saying a few words or have any comments either from the surveillance side or the public health entomology aspect of the house when it comes to alpha-gal.
Sure, I'm happy to jump in briefly. Hi everyone, my name is Dr. Eleanor Labgold. I just wanted to briefly pop in and say that there's been a lot of work looking at the Lone Star tick as being the potential trigger for alpha-gal syndrome. There's still a lot of research that needs to be done in terms of, why some folks might have a reaction following one bite, why some other folks it might take several bites. And there's also looking into, where if these ticks are born with the alpha-gal compound in their saliva or if they acquire it through various blood meals. So there's a lot of work that needs to be done on the entomological side of things. Also looking at the map that you can see up on the screen, there's some really interesting epi and entomological work that's happening to kind of chart the tick population density over with alpha-gal density as well. So it's a really evolving and emerging field right now, and I think there's a lot of exciting opportunities again for Virginia to really get ahead of the game and look at a lot of different factors for such a complicated and complex disease system. So I'm here in the background if anyone has entomological questions about the tick, but so far you guys are in great hands with Dr. Julia Murphy and with Dr. Weidman. So thanks so much.
Julia, is that it? Are you kind of wrapping things up and ready for questions, or is there more? I'm
You're
not
muted.
okay, I'm not hearing from Julia, so I'm assuming that we're ready for some of these great questions.
Oh,
go ahead.
I'm sorry, Sharon. I think I failed mute 101 in school, and I apologize. I'm off mute now. But yes, we're all wrapped up. I'm anxious to hear from anybody with questions, suggestions, mixed drink recipes, or however anybody wants to share anything.
There's some questions that people have entered via the question and answer feature of the webinar. Maybe we can start with some of those. From Leah Hamner, we have the question: for the investigations performed, are they solely using medical provider information / medical record information, or are investigators also interviewing patients?
Max, if you have any comments, please jump in. My understanding is that patient interviews are part of the local health departments, or for most local health departments, patient interviews are part of the follow-up. Maybe not in every single case, but certainly in some cases. Max, did you have a perspective on that from what you've seen?
Yeah, so I think the for these investigations in particular, the patient interview is particularly helpful because they often include quite a detailed diet history, and to kind of get the exposures of certain food products that might have been involved with the symptoms that are associated with alpha-gal, and also in documenting the previous exposure. So oftentimes it's the information that might not fully be conveyed to providers, and so kind of give the depth of the interview and to really check all the boxes that we need to not only know whether or not this fits as a case definition, but also when to assign it as a case definition, and how long the person's had these symptoms helps to have an in-person interview. I mean, not in person, but interview with the patient.
Thank you.
I think yeah, I think the deal is that with most local health departments, and Max seems to be echoing this from what the data he's seen, that patient interviews are often part of what happens at the local level.
Thank you. Here's another good question. And I think probably you'll have a better sense of this for Virginia than for the, for the nation. But Mark asks, oops, his question just disappeared. Mark asks about the distribution of the Lone Star tick. What's known about the distribution of the Lone Star tick in Virginia?
Sure. I'm so sorry I answered that question. So that's why it disappeared. So the Lone Star tick is pretty well distributed throughout the American Southeast. We in Virginia, we conduct tick drags every summer across the Commonwealth in various counties. And the Lone Star tick is far and away our most collected tick. We can find it pretty evenly across the Commonwealth, especially on those hot summer days where some of the other ticks might be hiding to try to take a break from the humidity. These little Lone Stars are just out and about. So they are our most frequently encountered tick here in the Commonwealth.
Thank you. Here's a comment from Representative Waxman, who's actually the representative who sponsored the bill that made alpha-gal a reportable condition in Virginia. And Representative Waxman says, I would just like to thank everybody for their work on alpha-gal. We have certainly come a long way in a relatively short period of time regarding public awareness. And thank you very much, Representative Waxman.
And just quickly, Sharon, speaking of outreach and education, we're currently working with our Office of Communications. It's in regard to a communication that we hope to have go out that will be sort of a joint communication between the Department of Agriculture and the Department of Health in regard to tick bite awareness. There's a tick bite prevention awareness week coming up later in March, and our communications team is working on some items there with some collaboration with the Department of Agriculture. So we're hoping that's going to be, I think that's going to be a really strong relationship and partnership there, talking across state agencies.
That's absolutely fabulous. And as you already know, I completely share your view that we need to focus more on prevention. We can't just keep allowing our numbers to grow and trying to come up with therapies. We've got to stop people from getting this thing. Scott London asks a really important and question for which the answer is nuanced. But I think that you guys are probably have thought a lot about this. How accurate is the alpha-gal syndrome blood lab test, by which I assume he means the alpha-gal IgE test?
Well, I think that, and that may be something that would be helpful to have a clinician's perspective. What I would say is that certainly we know that a lot of people are sensitized to alpha-gal. Not everybody who's sensitized to alpha-gal has alpha-gal syndrome. So I think there's more to be learned about alpha-gal sensitization versus alpha-gal syndrome, if that helps. And certainly, Sharon, I welcome your views on that as somebody who's done a deep dive in a lot of areas with alpha-gal, and Max and Ellie as well.
Yeah, I would say we do have data on this. When there's a high degree of clinical suspicion, in other words, when a doctor actually orders the test, there's a high what they call specificity to the test. In other words, 92% of the people, when a doctor orders the test because they think somebody has alpha-gal syndrome, will actually meet the clinical definition of alpha-gal syndrome, which, as Julia importantly pointed out, is a bit different from the case surveillance definition. But there are also folks who just get a tick bite and then run out and get the test. Not that many, but we hear about it from time to time in our community. And if you do that, then there's a very high rate of false positives. So I assume that one of the values of doing the surveillance in Virginia is try to figure out, how often does that happen, and try to identify those providers who are testing people inappropriately as part of a a tick panel in the absence of any symptoms consistent with alpha-gal. I actually have a question. There's still some great questions here, but I had a question. I had two questions. One was, it seems like there's a whole bunch of reasons why a suspected case might not be a confirmed case, even if you can follow up on it. Like, for example, there are those folks who just got the test, even though they didn't have any clinical symptoms of alpha-gal syndrome. But there might also be other things, like if you contacted my primary care physician, I'm not sure she would have enough information on my symptoms, to be able to confirm my case. And there are other times when perhaps you can't reach the patient. So are you tracking data on that, on kind of like what is causing suspected, what's the sort of spectrum of reasons why cases might not be able to be confirmed? And then my second question, and I know it's really annoying to ask two questions at once, but so I apologize. But the other question is how relevant is the kind of surveillance that you do for Lyme disease, which everybody has more experience with, to alpha-gal? Is the process pretty comparable and the methodology translatable, or are you finding that it's really different?
Well, I can offer a perspective on the first question first, and some of it may be it's a little too early to tell based on the amount of data we have so far. When it comes to our public health case surveillance definitions, we have a couple of different categories. We have confirmed, we have probable, we have suspect, and we have not a case. So if a suspect case, in our language now, in our language, the public health language, a suspect case is typically going to be a case where we have a lab result, but we have no clinical data. So we don't, if for some reason, whether there wasn't the resources to investigate the case, or whether an attempt was made to investigate the case and it could for some reason never be completed, we only have a lab result. In that case, in our language, in the public health language, would be considered a, quote, suspect case. If we have clinical data, if we're able to get clinical data that we can square against the laboratory result we have, we then would be able to set about categorizing the case in essentially with alpha-gal, one of two ways, because our probable case definition includes a skin test, which very few people ever do anymore. So really, we're kind of down to, if you have a lab result from a commercial lab and you're able to couple that with clinical data, essentially what the local health department will be able to do is categorize that case as either meeting the definition, our public health case surveillance definition of confirmed, or if that person's clinical information does not square with the clinical aspect of the definition we use, then we would categorize that person as, quote, not a case. So in other words, for our purposes in public health, we would not count that person as a case writ large of alpha-gal for our purposes. So I think there's more yet to be learned based on the number of cases we have to even assess at this point how that's going to play out in regard to what we learn concerning why people are tested. How are people being tested just because they had a tick bite, but they otherwise don't have any sort of clinical suite of symptoms that might even suggest they have the actual syndrome? Are providers really targeting and drilling down on the clinical symptoms? Like you said, Sharon, earlier, when we have a combination of a positive test and a clinical suspicion, that somebody is manifesting disease that could be compatible with alpha-gal, then we've got a ball game. And that's certainly what we try to emphasize to providers. You want to have and that's not just with alpha-gal, that's really with any syndrome. You want to try to be driven by a clinical suspicion of a particular condition before you test, and see if the two marry together to support your idea. Now, I think that was the first question. Now, the second question was sort of Lyme, at where we are with Lyme disease surveillance as compared to alpha-gal, and maybe what some of the lessons learned from Lyme disease surveillance are, and where we are. And if that is that fair? Is that,
Yeah, I'm kind of just
would that
wondering
be
how
good?
translatable it is, whether you can just say, oh, well, this is
Well,
what we do with Lyme and that, so we'll just apply the exact same thing to alpha-gal.
right. And I think it's fair enough to say we might get there someday. We might get there someday. Now with Lyme, we had about got to go in the Wayback Machine a little bit, because with Lyme, we had about 30 years of public health data there to understand how Lyme was emerging in certain states, in communities, to have sort of a clear handle on the typical constellation of symptoms and uh, uh, medical impact, if you will, that Lyme has on people. And so over time, our surveillance method and strategy evolved because we felt like with all that data and with all of the consistent features that we saw year after year with Lyme, as far as the constellation of symptoms and the outcomes and impacts clinically of Lyme, we felt that we were in a place, at least in certain states, where we felt that coupling laboratory reports with the clinical was really, for public health purposes, probably not going to further our understanding of Lyme much more than we already knew about Lyme in certain states, in what we call our quote high incidence states for Lyme. Now, the high incidence states for Lyme make up maybe a third maybe of all of the states in the United States. So a goodly number of states in the United States still do traditional surveillance, what I would call traditional surveillance for Lyme disease, which is they get a lab report and then you set about investigating the case and trying to understand if somebody has clinical symptoms compatible with Lyme disease. You marry the laboratory and the clinical, and you see what category how you would categorize that case. In some states, and Virginia is one, that have year after year where Lyme has emerged, we are now considered a high incidence state. We are one of those states where gathering clinical data associated with Lyme is not done anymore. In other words, we have a laboratory test only way of doing surveillance for Lyme disease to monitor trends over time. Now, comparing that with alpha-gal and where we are right now in our alpha-gal journey, we're in our infancy with alpha-gal. We also know that a lot of people, there's a certain percentage of people who are going to test positive for alpha-gal but not have the syndrome. So we feel we're in a posture right now where having that clinical piece is important to us, and it would be important to try to, as many times as we can, using this strategy, apply our case definition, which marries the laboratory test and the clinical symptoms that a person is experiencing, to see if they seem to have the syndrome. Now, maybe years from now, 5, 10, who knows, years from now, maybe if we gather enough data, maybe we will be in a place where we are now with Lyme, which is that we have a good baseline established understanding of how the clinical impact and suite of symptoms in residents of Virginia, and we might feel we could fairly transition to a laboratory only model. I think we may be a little early in the game for that, but I think that the lessons learned from Lyme are such that maybe you would be able to transition to a laboratory only model at some point, and that you certainly have to try to consider the burden of disease and the resources you have to investigate when you are trying to create a surveillance strategy, because that was one of the challenges with Lyme, that in certain states, the burden of the reports was such that there was a real challenge investigating. And so that, in some ways, that was good because it forced us to think. It forced us to think, why do we do surveillance? how do we use this data for public health action? How can we fairly continue to monitor and use this data for public health action while still right-sizing our surveillance and making sure that we're using our resources wisely. So I hope that helps. Maybe that helps. Don't know if it
Yeah,
helped.
absolutely fantastic information there, as usual. Thank you so much. So I want to say at this point, that I don't want anybody to feel like they have to hang out any longer. If people do want to hang out longer, there's some really great questions. And if people don't want to hang out longer, I'm going to do my best as a technologically inept person to download these questions, and try to get as many of them answered as possible. Um, so where are you all? You ready to take off, or are you going to hang around to answer a few more?
I'm happy to stay if folks have questions.
Yeah, also happy to stay.
Oh,
I
good.
Oh, I do have to jump, but I think I got most of the entomology questions. But if anyone has further questions, feel free to send them my way, Sharon.
Well, thank you so much. I'm actually
Yeah.
amazed, given the fact that you're a new mother, that you showed up.
Yeah,
So deeply appreciated. And also just thank you for all the amazing work you're doing in Virginia. Like,
of course.
so means so much to our community. So thanks a
Thank
lot.
you so much for having me tonight. Thank you, everyone, for being here. Thanks. Bye.
Bye bye.
Well, you're muted, Sharon.
Oh, I just said, Max or Julia, if you're seeing any questions there that you particularly want to answer, there's some really good questions, but maybe you've
Yeah.
identified your address.
Um, I see a few I see a few questions about UVA. Yes, we absolutely are very respectful of UVA. They're a great center of alpha gal research, and Dr. Platts Mills, one of the people who really first helped to characterize and discover alpha gal, if you will, in the United States. They did they are as healthcare providers are reporters to the health department. We hope to partner with them more in regard to alpha gal surveillance, and they're certainly a great center of research and alpha gal care. I see a question here about if state legislators were hesitant to support the bill. I don't have any knowledge that any legislators were hesitant to support the bill. It passed through the General Assembly. I don't believe anybody had any hesitancy. I mean, there was discussion about the burden and what that was going to mean, but to my knowledge, I'm not sure the exact vote, but I don't believe that there was much hesitancy there.
Yeah, I think wasn't my impression either, but if Representative Waxman is still here, he might have had to take off and attend to uh, the business of government. But if he's still here, he might have something to add. Representative Waxman, let me know if you're here and you want to address that.
There were also a couple of questions I noticed regarding the case report form or having cases that so I think it was Mark Pruitt mentioned having well, so many cases that it would be challenging to report them all. Um, so yeah, that was something we didn't really bring up in the presentation, but we also have we call a morbidity report form as another pathway in addition to the positive lab results for there to be a kind of a case investigation uh, launched, and so that's something that we're also trying to kind of factor into the system of how to make it easier for the local health districts to do these investigations. One way that's come up as a possibility is encouraging for more of these case report forms to be filled out, and they're based on the CSDE case definition. So the form is kind of tailored to gather the information that would allow us to categorize the case based on the CSDE criteria. As far as the number, the large volume, I don't know if there's really any easy answer to that, but I would think that really any uh, amount that could be filled out would kind of lessen the burden on those who are performing the investigation, make the investigations a little more streamlined, and have more complete data that we could that would add to the quality of the surveillance system.
I see a question, and Max may have alluded to it, about criteria that defines alpha-gal syndrome. I guess I could say, if you're interested in looking at the criteria we use for public health purposes, so our perspective, our worldview would be looking at a collection of information on a patient vis-a-vis the public health case surveillance definition that we use. Public health case surveillance definition, and I'll drop this in the as an answer there, can be found on the CDC website. So I think I put it in there. I'm not sure what I'm doing. Maybe I'll put it in the chat, or I'm not sure how you do that, but there's a chat, right? You can, if I'm failing you, I apologize. You can also just Google CDC surveillance case definitions, and that'll take you to a page that has case definitions, both for the types of, for various diseases, and they're just listed alphabetically. So if you want to see the criteria we use to apply when we get a report from a clinician or a lab, that it's there on that page under alpha-gal syndrome. And when it comes to sort of the defining line between testing positive for alpha-gal and having alpha-gal syndrome, that would be testing positive plus having the constellation of symptoms that people with alpha-gal can have. So there are people who are sensitized to alpha-gal such that they test positive, but they may not have the syndrome per se. They may not have the clinical symptoms that are seen in people with alpha-gal. And when it comes to distributing information about alpha-gal to doctors and ERs in Virginia, we can always do better in our outreach. We're always trying to do more outreach about alpha-gal all the time. But the clinician letter that I mentioned earlier in the presentation, when I was talking about how we're doing surveillance, we're trying this method. Early days, we need to continue to evaluate to see if the data we are getting is of quality and is reasonable to use for public health action. I also talked about the fact that we're now have launched into a good bit of outreach and education. And we sent, when alpha-gal first became reportable, we sent a letter to all clinicians in Virginia to indicate to them that alpha-gal is now reportable, the mechanism by which there can be reporting, and also pointed them to our Virginia Department of Health ticks page that has a specific aspect to it that's solely focused on clinician resources for various tick-borne diseases. Of course, alpha-gal is in there as well. And we've been trying to highlight a patient information sheet that I have to say, and I thank Sharon for this, was very heavily inspired by the fact sheet and patient information sheet that alpha-gal information can be found on the alpha-gal information website, which is great, a tremendous website with a ton of information. And we rather fashioned our patient information sheet after that, because we also heard from our local health departments and some of our regional staff that what they were hearing from their clinicians in their districts is that it would be helpful for clinicians to have something they can hand their patients when they have diagnosed them with alpha-gal syndrome, so their patients could read through it, their patients could have resources for additional information. And so we created a patient information sheet that is there as part of a clinician resource, so that healthcare providers can know that might help them with patient education and information.
Thanks for those kind words. And it was alpha-gal syndrome expert Scott Cummins who told me what doctors really wanted, these handouts. That's why it inspired us to. So I'm just really happy to see that you're doing that. We've got a question here from Emily Pickle that I think is quite interesting. Her question is, does the investigation case report form is it based on the CSTE criteria, and does it include information on known tick exposures, tick-borne disease diagnosis, etc.?
Well, yes, the case report form we use is based off of the case definition. So it's going to contain all of the elements that are in the case definition and the various aspects of that, clinical as well as laboratory. And we do ask, as part of our case report form, about tick exposures. I hope that helps.
Thank you. I also just had another quick question. When this communication is going back and forth between providers and the department, at any point have you found a way to incorporate information about that CDC AGS training module into those communications for providers who might not be aware of it?
I believe that went out. I'm trying to think when that communication, that CE first came out. I thought we included that in our initial clinician outreach. I do have to say, since it's early days, we need to, I hope to do this especially during May. May is when traditionally was our Lyme disease awareness month. Now it's Lyme and other tick-borne diseases awareness month. And we have social media messages that we've sent out over the years, and now we have some alpha-gal specific ones in development that can not only for members of the general public, but also that target clinicians on certain platforms where clinicians might go, whether it's the VDH clinician Facebook page, whether it's LinkedIn. So we're hoping to do, more and more alpha-gal specific kind of outreach and really highlight that CE, because it's really good. I mean, I've taken it. I think it's really fantastic. It leads you through and it's very engaging. So the more we can highlight that. So I don't think I'm telling lies, but this is being recorded, so we can come back at some point and see if I've told a lie. But I believe that CE came out before we sent the clinician letter at the end of September last year. And I think we included it in that. If nothing else, where we did upload it, we uploaded the link to that CDC continuing education to our website, to the VDH website within the clinician resources on alpha-gal. And certainly that was a website, that vdh.virginia.gov/ticks, that went out to all clinicians. Now, certainly, again, we need to keep pulsing that information. We need to keep reaching out, because, again, outreach, just like evaluation of a surveillance system, it's not just set it and forget it. It's not just one and done. There are always going to be new people entering into the clinical space, and we'll need this information. So it's a continuing process.
Thank you so much. I agree. It's absolutely fantastic. All right. Any other questions that anyone's seen there that they're hoping to answer? I see something from Deb Manzari. Is the Department of Health considering using self-reporting with proof of medical labs or clinician acknowledgement as a way to capture data?
Well, I appreciate that question. And we're always, we have, when we first started thinking about how we were going to do surveillance and how we were going to tackle this, that was one of the things that we talked about, is what would that look like, and how would we connect with patients? What does that look like from an information technology standpoint? How would that work? And so I think it's certainly early days in our journey here. We're going to have to evaluate how much of a quality data set we can gather with this method. And certainly we will, I'm wondering if we will likely to need to discuss other methods that perhaps would complement what we're doing now or even replace it as time goes on. So certainly appreciate that. And we're always trying to think of how can we do surveillance better, either figuring out something that's complementary to what we're doing or is another process whereby we could get quality data for action.
Thank you, Julia. I see another interesting comment here, but does anybody else have a question there that they're hoping to answer? Let me know when you guys are completely worn out.
I see one that asks about coordinating with other states. We do have Virginia participates in an interstate alpha-gal group, mostly made up of state partners that also do vector-borne surveillance and involved in public health surveillance associated with vector-borne disease. We're very fortunate to have CDC partners as part of that as well, to help in partnership with our federal brothers and sisters to better understand how we can go about a number of different things when it comes to alpha-gal, whether it's outreach and education, whether it's tick bite prevention education, learning more about the Lone Star tick, and also how states are that the states that are doing surveillance, how are they going about it and how is it going for them, so that we can always stay in touch and learn from each other when it comes to alpha-gal, whether it's on the communication side, the surveillance side, various in various ways. Well,
you all have been at this for an hour and a half now. I'm going to try to download these questions, and as I said, I'm kind of inept, so I can't promise you that I'll succeed. But please feel free. When for the webinar follow-up, you'll get my email. Feel free to email me questions, and I'll try to answer your questions, and those that are appropriate for Julia and team to answer, I will try to forward to them. I just wanted to say that when you're off doing your epidemiology, I don't think you have that much contact with the patient community, but if you did, maybe you'd have a better sense of just how much this means to us. The work that you're doing, everybody in our community is following it. Everybody is so excited about it. Everybody is so deeply, deeply appreciative of what you're doing. We wouldn't be anywhere if it wasn't for epidemiologists. Nobody would even believe that there was an alpha-gal syndrome problem in this country. So many people haven't heard of it. So many people think that it's rare in their state. So many people think that there's just a few thousand cases in the country. So we couldn't be more appreciative. You really are heroes, and I want to thank you from the bottom of my heart, not just on my behalf, but on behalf of the whole community.
Thanks so much.
we
really
sure appreciate
means
it.
a lot to hear
And
that. Oh, sorry.
yeah, we appreciate it. We're happy to do it. We just want to make sure we try to get it right. That's the thing. You start out on something, it's not magic. It's just looking at the data and asking yourself, how do we do this? And then continue to evaluate and be try to continue to be a good critical thinker about what you're doing, why you're doing it, and how you can apply it. Because if you're going to use data for action, you obviously want to make sure the data that you're using is reasonable. And so we're in that stage right now of trying to understand, is the data we're collecting applicable broadly? Is it representative? If it's not, how do we pivot and figure out the best way to understand trends and also present data to various interested stakeholders. So we certainly appreciate being invited and everybody's time and everybody's efforts, because I think we're stronger together here if we communicate and we're can help force multiply in our efforts.
Well, thank
Yeah.
you so much.
I just want to also thank you so much for your questions, because many of them can be very informative for us too, about getting perspectives from clinicians, from patients, and so yeah, it's, I think, very helpful to be in touch with people whose lives are really affected by alpha gal, and whose practices are affected. So thank you.
Well, we're gonna uh, we're gonna try to do our part by doing everything that we can to ensure that you actually have, the resources to do this. And so on that note, thank you so much. I absolutely love this webinar myself, and I appreciate you taking your time away from your evenings to do this. And I look forward to next year's update webinar. No, I'm just kidding. I haven't talking about that. But we'll see, right? So thank you very
All
much.
right. Yeah, we'll see.